the officers and all the delegates who have joined us for this FARO webinar. Uh, I welcome again to all of them, and I'm very sure that it will be a very useful meeting and the fruitful meeting. I think as you know all that the FARO, as Professor Tati has mentioned, uh, it has initiated in 2012, November 2012 at Kyoto in Japan. So the whole concept has emerged at that place that we should have a Asian organization for radiation oncology. And the first meeting of the FARO, as a first official meeting of the FARO, was held in 2015. So that was the great day. We had the first meeting at Kyoto again. Then the second and third meeting, so practically every year, and sometime it was decided that we should have the alternate years. So that is also in offing with us. This is the third FARO webinar. The first two we had initially, and the third one we wanted to keep, especially the common diseases which are seen in the Asian region. So this is the head and neck cancer, and current very hot topic is there about the hypofractionation, because we are all talking about the hypofractionation. And I think the reason is very simple for all of us, that we always think that patients should get the treatment as quickly as possible. So all nowadays, if you look at the radiation therapy for the breast cancer, and so this is also a sort of hypofractionation which is mostly accepted. And similarly, in the head and neck cancer, we would like to really see that. And I'm very happy that we have got the very eminent the members here who are the expert in head and neck cancers, Professor Kenneth Hu, Dr. Tejpal Gupta, Dr. Ann Lee. You will be definitely hearing about their publications, and Dr. Qazi Mustaq Hussain from Bangladesh. They are going to really take us forward for this meeting to show that what is the current status and how we should practice our radiation oncology. I'm very happy with all the officers and the council member of the FARO who have put enormous efforts in bringing these topics and bringing this the webinars. And I'm really thankful to the team, young team from the Indonesia, under the guidance of Professor Tati, who has brought this webinar, and she continues all the efforts despite staying at home. The whole team is still working and really putting their hard work in bringing these webinars. And I'm sure that this will be very helpful to all the relatively, I can say, about the junior members, and also the teachers. This is going to be a very important aspect we will be learning. So I'm really waiting for all the deliberations from United States, from India, and from Hong Kong, and from Bangladesh, to really give us the thought that how we should practice and what we should do. And I'm really very thankful to, again, the young team for the FARO from Indonesia who has organized this. And there are a lot of young people from Japan who have also contributed in various activities of the FARO. So thank you very much. And again, I welcome you all. And please let us know if from the Asian region, if anybody, and nowadays I can see that nearly more than 300 people have already joined, and I'm sure that some other are going to come and join. If you have some topics, if you want to do something within the Asian region, please let us know at the FARO office. Professor Tomo is there. You can really communicate to him, and he will be really very happy to really circulate among all of us. Unfortunately, what I can see that the Professor Nakano, who has been very active, is not able to join, but I'm sure in coming meetings and the webinars, you will be definitely seeing him talking to all of us. Thank you very much, Professor Tati. Thanks. Back to you.
Yeah, thank you, Professor Syam. Now, dear all colleagues, please welcome Professor Miriam. Professor Miriam, I'm sure that I don't need to introduce again who is Professor Miriam, especially in our region in Asia. But I would like to say that Professor Miriam is the chairman of the FARO Education Training Committee. She is the senior radiation oncology from Sindux Hospital, and as well as the former head of the radiology department in Philippine General Hospital. And Professor Miriam is the good friend of Professor Kenneth Hu. So Professor Miriam want to say some special things to Professor Kenneth Hu. Please, Miriam. Miriam is my best friend, so.
Thank you, Professor Tati, Syam, and the rest of the distinguished speakers and officers. And it's my pleasure. Good evening to all of you. It's my pleasure to invite my very good friend, Dr. Kenneth Hu, an expert in his field, and just a very short background about how we met and how we were able to invite him tonight was that we met during the ASTRO meetings. He's very active in the International Educational Subcommittee, of which I was also a member. We first met in 2009. At that time, my colleagues from the Philippines were busy looking for ASTRO lecturers to invite over to give us lectures. And we actually went to Dr. Nancy Lee first. And Dr. Nancy Lee, who was not able to join us the following year, introduced us to Dr. Kenneth Hu. And that started our friendship. As he came to Manila the following year, that was during the ASTRO IAEA CRO Cross meeting. We combined this in the region. We invite the members of the CRO also. And Dr. Kenneth, who conducted the first e-contouring class in the country. And that's how he started. I think later on you will hear from his biodata that he is very active in the e-contouring classes and courses. But anyway, he came back again to Manila, Best of Astro 2017. He came to our house and met some of the residents, and the residents asked him, "Why are you a radiation oncologist?" And what was his answer? His answer was because he has some relatives who have cancer, and that's why he wanted to give them treatment without having to use surgery. And that's why he is a radiation oncologist now. Other highlights of our friendship, he went to Taal volcano. I did not go with them. And he walked there, and that volcano erupted just last year. So that was a very good opportunity for him to see the volcano before it erupted. Then so many other meetings every year in Astro, in Icaro, we met in Bali also, in Shenzhen during the FARO meetings. In other words, he has become a very favorite speaker because it's easy to invite him. Our friendship started because we always talk about educational activities. So tonight we have Dr. Kenneth S. Hu because he loves to talk about teaching, and he loves teaching very much, and so that's easy to invite him. And that's how our friendship started. Thank you very much, Dr. Ken Hu, for being with us tonight.
Thank you very much, Miriam. Yes, Professor Kenneth Hu is already helping us a lot in the FARO. As it is mentioned also by Miriam, he was also in Bali. And also, he also made a lot of friendship with all of us. And then now, just we have to start the meeting. So I would like to call Professor Kazi. Professor Kazi is the senior radiation oncologist from Bangladesh, and he is the one who will lead the scientific session for tonight. Please, Professor Kazi.
Thank you, Tati Madam. Good evening, good morning, dear friends and colleagues from all the FARO countries and from all over the world. I am Dr. Kazi Mustaq Hussain from Bangladesh, moderating today's session. Today, we are attending the third FARO webinar on hypofractionated radiotherapy in head and neck cancer during and beyond COVID-19 pandemic. We have survived 2020, the last year that was different than any other year near past. The COVID pandemic has changed our lifestyle and also the treatment protocols. The question is how long this pandemic will stay despite giving started the vaccination, but it will take few years to vaccinate 7 billion people of the world. The FARO region contains almost 1/3 population of the world. Many countries of the region are still belong to the developing and least developed countries. The economy and the social diversity of our countries and people makes it difficult situation for us to manage diseases like cancer. Hypofractionated radiotherapy is widely used in the treatment during this last 1 year, and will we use it in future regularly, or how long should we continue hypofractionation? Already Professor Sham has told some importance about the hypofractionation, because we want that as how early possible to deliver treatment to our patients. We will listen to Dr. Kenneth Hu, Associate Professor and of Radiation Oncology, New York University Langone Medical Center, about the present and future direction of hypofractionation in the treatment of head and neck cancer. We'll take some questions in the Q&A box. Please write your question or comments here. We have 30 minutes for discussion after the panelists' comments. And we have heard from Professor Sham. He is the current president of Federation of the Association of Radiation Oncology. We have two panelists today. Professor Ann Lee is currently clinical professor and head department of clinical oncology, the University of Hong Kong. In addition, she is the chief of service of the Center of Clinical Oncology at the University of Hong Kong Shenzhen Hospital in China, and the chair of specialty for oncology at Gleneagles Hong Kong Hospital. She is also the honorary consultant departments of clinical oncology at Queen Mary Hospital and Pamela Yodo Nethersole Eastern Hospital in Hong Kong. Our second panelist, Dr. Tejpal Gupta, professor at the Department of Radiation Oncology, Neuro-Oncology, and head neck disease management group in Advanced Center for Treatment Research and Education in Cancer, that is ECTRIC in Mumbai, India. He is he's the member of many national and international organizations. Today's speaker, Kenneth Hu, has already been introduced, and we have heard many interesting talks on him from Medium. He has dedicated his career to the practice, research, and teaching of head and neck cancer radiation oncology, involved in national and international level. If I start telling, it will take all the time. So in short, I can say his contribution can broadly classified into 4 major areas as follows. Number 1, precision targeting of head and neck cancer treatment. Number 2, the application of brachytherapy approaches in the treatment of tongue cancers for organ preservation. Number 3, development of a multidisciplinary algorithm to treat paragangliomas of the head and neck. And number 4, global health education. Ladies and gentlemen, I welcome and request Dr. Kenneth Hu to start his presentation. Dr. Kenneth Hu.
Hello, Dr. Kenneth Hu.
Hi there. Hi there. Can you hear my screen by any chance?
Yes.
You can. Okay, great. Thank you so much for the wonderful introduction. I really feel privileged and honored to be able to speak at this virtual webinar. As Miriam explained to you, have had a very nice relationship where Miriam and I met and worked on the Astro International Education Council in multiple different ways over 10 years. And, you know, it's just been a pleasure to see the formation of FARO and being able to participate from its inception. It's been wonderful. I do remember fondly the occasion we had in Bali, especially Tati's performance. That I don't think I'm going to be able to emulate her dance talents, but I hopefully can entertain you with some data and this presentation. So it's tough circumstances to meet under these circumstances, but in some ways we've been able to get such a significant number of participants focused on a lecture because of the format that we're faced to deal with under this COVID pandemic. and this is a topic that is obviously a universal one. And I had been talking to Miriam about some of the topics at Astro that was of interest, and this topic about the use of hypofractionation, as Dr. Sham had explained, you know, is clearly very well established in breast cancer, but not quite so much in head and neck. And before I go into that, I just want to let you know that these are some of my disclosures. I am an employee at NYU, but also am a member of the Astro International Council, which is a new variant of the Astro Educational Subcommittee that was part of the overall Education Committee, but now is a standalone committee demonstrating Astro's commitment to global health. So I look to be able to participate with FARO in multiple other circumstances and projects. And I also have been a consultant with the IAEA.
Dr. Hu, I'm sorry to interrupt. Could you please turn off one of your speakers because there's an echo that we hear over here?
You hear an echo? Okay, let me just.
Can you please say something again?
Hold on for a second. Let me just mute. If you can mute me, I have a call in.
Okay.
You have me muted? Oh.
But there's still an echo. I think you have to turn off the speaker on one of your devices.
Yes,
Actually, you were logged in from two mobile or two laptops.
Hold on for a second.
Can you do it from your end, Mayank?
Now I think I got it.
Yes.
Better. Wonderful.
Hey.
Thank you.
I don't know if you ever watched that. There's a very popular series called Get Smart in U.S. that I was raised with, and there's a scene where there's a cone of silence where they're trying to be discreet, and they put each other in a cone that descends, and there's an echo that keeps going on, and the echo keeps reverberating. One person hears it and one person doesn't, and it drives the other person who hears it crazy. So sorry for putting you in the cone of silence there. But to carry on, this topic of hypofractionation is highly relevant, as Dr. Sham had alluded to. And so at ASTRO this past meeting, there was a international meeting talking about the use of hypofractionation in breast, prostate, and head and neck cancer that we performed. And a lot of the excerpts do come from that, but it just highlights the importance of understanding this topic and seeing how we can move forward with this given the circumstance that we're under and also beyond. So the issue of hypofractionation actually came up as a consensus, ASTRO consensus statement, where over 30 experts from ASTRO, ESTRO, and selected Asian countries were asked in a modified Delphi process of iterative surveys to discuss how they would treat 7 head and neck cancer cases, oropharynx, both P16 negative and positive, early and advanced stage larynx cancers, oral cavity cancers that have been resected with either negative or positive margins, and how you might want to palliate a patient with an advanced hypopharynx cancer. And this was, the question was posited under 2 COVID scenarios: an early pandemic scenario when you're trying to consider risk mitigation, and a late pandemic situation where you have extensive infection and severely reduced radiation resources, not only availability of machines, but staff and physicians to run it. And so some of the interesting points that came out of this is demonstrated right here. For those patients who are positive for SARS infection, there was a strong agreement to delay the initiation of treatment, even though we know that head and neck cancers can grow quite quickly, and that the time to treatment from the diagnosis is important. Nevertheless, the overwhelming impact of COVID infection was significant enough that if a patient had not started, that there should be a delay in their treatment until their symptoms resolved.
Sorry,
but what?
Dr. Hu, sorry, we're not seeing your screen.
Oh, I am so
Yes.
sorry.
We cannot see your PowerPoint.
Okay, let me see here. I'm showing this from. Can you see it now?
No,
Not yet.
not yet.
How about now?
Yes, we're seeing your screen, but it's not the PowerPoint.
You see my screen? Okay, let me just pop it up.
Yes.
You see that now, right?
Yes.
Yes.
Okay,
Yes.
I'm sorry.
Okay.
Yeah, it's a little tricky in this day and age because I had to use a virtual network from my office because the PowerPoint package was actually quite extensive, and so I had to access it through there. And then there's firewalls in my institution, so we had to do a little fancy footwork. But I think we figured it out. That's why you don't see my face. You just see you hear my voice as I'm calling in, and you see my screen from my network desktop. So sorry about that. But anyway, so in continuing, so if a patient is diagnosed with COVID, there is strong agreement not to initiate treatment, even though there might be some impaired consequences, but the overwhelming impact of and detrimental impact of a COVID infection prevents you from starting the treatment. But if a patient does have COVID diagnosed and has started radiation treatment, especially during the first, especially after the second week, and has mild symptoms, then there is strong agreement to still proceed as long as they have mild symptoms to completion of treatment. But of course, if they do develop severe symptoms, the treatment must be disrupted. So in terms of a early pandemic scenario where risk mitigation is important, there was general agreement that the fractionation should be considered conventional fractionation, whatever that might be, and to use concurrent chemotherapy during the radiation for these advanced stage patients, basically not to change your standard of care, and to continue using the chemotherapy and the radiation on standard schedules. There was also a strong agreement not to use induction chemotherapy as a bridge to treatment. For the late pandemic situation, where we have severely limited resources, the use of hypofractionated radiation was advocated. There was strong agreement about that, and to consider using chemotherapy only in fractionation schemes where the dose per fraction is less than or equal to 2.4 gray per fraction. Again, using induction chemotherapy in this situation, whether you're doing hypofractionation or conventional fractionation, was not recommended. So I bring this data set up because we're going to go into the suggestions for oropharynx cancer, both in HPV positive and negative, and you see that for patients with HPV positive cancers, there's about a 25 to 30% survival benefit compared to those who are HPV negative. And when you look at this, Ken Ang had reported in this New England Journal article that you can bin patients with oropharynx cancers by their HPV status, primarily by the number of pack year smoking histories that they've had, and then by their classic TNM staging. So for patients who were in this trial that was looked at where all patients got concurrent chemoradiation, about 2/3 of the patients were HPV positive. Less than about 20% of them had less than a 10-pack year smoking history, and the other half had greater than 10-pack year smoking history. If you looked at their smoking history and they had less than a 10-pack year smoking history or P16 positive, they were considered favorable risk or low risk patients in this recursive partitioning analysis. If they had greater than 10-pack year smoking history and only one lymph node, N1 or an N2 lymph node, they were also considered low risk. On the other end of the spectrum, if they were HPV negative and had greater than a 10-pack year smoking history, they were considered high-risk patients who would not do well with this standard concurrent chemoradiation. But if they were HPV negative and still had less than a 10-pack year smoking history and had a relatively intermediate-sized primary tumor site, they were considered favorable, intermediate risk. And so you could see that if you classified oropharynx cancers by these criteria into favorable risk, intermediate, and high risk, you can see a spread of outcomes of about 20%. So favorable risk patients would have a very high outcome, and high risk patients would have a very modest outcome, the classic 50% cure rates that we normally had seen in the past. I bring you back into this, back to the consensus statement, excuse me, that for in the high-risk situation where you have a P16 negative patient, if in the early pandemic scenario, there was strong agreement that patients should get concurrent chemotherapy with conventional fractionated radiation. And similarly, for if you're HPV positive, you should also get concurrent chemoradiation with conventionally fractionated radiation. However, when you're under severe limited resources, there was a toss-up for the high-risk patients whether you should get concurrent chemotherapy, although 50% of the panelists did think that the high-risk situation did warrant giving chemotherapy. But if you were in the favorable risk patients who might do well even without chemotherapy, 3/4 suggested that you'd give the radiation without concurrent chemo. So this brings us to the situation of how we would treat patients under the late pandemic scenario. And there was strong agreement that hypofractionation was a very good choice. However, the type of hypofractionation was across the board in terms of what is the best regimen. So if you can see here on the far right column, hypofractionated radiation was defined as giving 2.4 to 3 gray per fraction. But amongst the different regimens out there, the most common one that was advocated was this 55 gray in 20 fractions. A 4-week regimen. There was a 3.5-week regimen as well as a 5-week regimen that I'm going to discuss the top of the 4-week and the 5-week regimen in more detail as the talk goes on. But you can see that there was no consensus exactly as to what type of hypofractionation scheme should be utilized. I think a lot of the panelists, both from Asia and Europe and in North America, don't really have a good experience to really feel strongly about which is the best one to use. And the reason why is because we've spent decades trying to see how we can maximize treatment, dose intensification, understanding that unlike a lot of solid tumors and head and neck cancer, we have to deal with this issue of tumor repopulation that begins typically about 4 weeks after the initiation of radiation treatment. Rod Withers, who was a former chairman at UCLA, dedicated his career towards understanding all these data sets of definitively treated head and neck radiation, and he was able to come up with this chart that showed that to optimize outcome, looking at the y-axis as the dose needed and the treatment time, that you needed, as the treatment time progressed, you needed subsequently higher doses of radiation to get the equivalent cure rates. So because of this concept of delayed tumor repopulation, the head and neck cancer cells, once they sense radiation and they are dying, activate a set of signals that makes their tumors divide more quickly, so that by after the 4th week, you're in a race to try to complete radiation as soon as possible. And so many trials for decades were looking at using accelerated or hyperfractionated radiation to give higher dose of radiation, or accelerated radiation to decrease the treatment time to less than the 7 weeks. And the common accelerated radiation regimens typically that hit the sweet spot of not too much toxicity but yet being effective was reducing the treatment time by 1 week. Hyperfractionated radiation used the same treatment time of 7 weeks but gave BID radiation to a total dose of 80 gray, whereas the accelerated radiation arms kept the same total dose of 70 gray but delivered it 1 week less. And by doing so, with all these very high-quality randomized studies, they were able to show a local regional benefit of about 9% that translated into a survival benefit of about 5 to 6% when you look at these large meta-analyses that Jean Borges was very good at bringing forth. So I mentioned this because this is really the regimen that was pioneered by the Danes, Jan Overgaard, that was put forth globally in a randomized study through the IAEA. Many of your countries probably participated in this important trial where they randomized patients to 6 versus 5 fractions per week, and were able to show, and so these are some of the participating countries that I put forth, because we are talking about FARO setting. A lot of the member countries are joining us in this talk. So you should be very proud for participating in this trial. And was able to show that the DAHANCA regimen of 6 fractions per week improved local regional control by about 10%, and that translated into a survival benefit significantly of about 7%. But still, nevertheless, even though you see the benefit with accelerated treatment delivering 70 gray in 6 weeks, you see that the survival, even though it's improved, is still quite modest. So a lot of people thought that in this setting, concurrent chemotherapy is still useful to try to improve outcomes even further. But when you looked at accelerated radiation versus conventional in the setting of concurrent chemotherapy, multiple trials have shown no difference in accelerating the radiation versus conventional fractionation. So as a result, many institutions transatlantically and transpacifically have used standard fractionated radiation. So it's only been very selected groups of selected countries that have evaluated and pioneered hypofractionated radiation regimens. And I'm going to mention two sets of data sets using the 4-week and the 5-week regimen. We get most of our data from the 4-week regimen, that's at least in the published literature, from the Brits at the University of Birmingham. And they published their series where they gave 55 gray in 4 weeks, very similar to what was recommended in the ASTRO guidelines for hypofractionation, looking at oropharynx cancer. And they were able to, in a modern age, molecularly profile these patients as either P16 positive or negative, that in their 85 patient cohort, 2/3 were P16 positive and about 1/3 were P16 negative. They were also able to get concurrent chemotherapy, which is very modern. The majority of them received concurrent carboplatin, and others received cetuximab. The standard chemotherapy regimen that was normally used with radiation is typically weekly or high-dose cisplatin, but I think the authors were concerned that with this hypofractionated approach that maybe high-dose chemotherapy, the standard regimen, may be too tough on these patients. So they use what we call a more radiosensitization light regimen of carboplatin or cetuximab, and about half of them got induction TPF chemotherapy. And when you look at the results, first of all, they had a median follow-up of about 2 years, and you can see that even though the treatment course was short, many of these patients required a feeding tube and hospitalization to get through the treatment. Typically, I would say near the end of the treatment is where they start really feeling the effects that require this kind of intervention. But you could see that despite the tough treatment, many of them were able to finish, and the outcomes were quite respectable. For P16 positive patients who were never smokers, the local regional control rate at 2 years was about 87%. For patients who were P16 positive that had a smoking history, it was slightly decreased. But then again, of course, for the P16 negative patients, their outcomes, local regional control was only about 45%. And you look at the survival rates that correspond to these different subgroups. And I know many of you have participated in this other very interesting trial by the IAEA, where they've looked at using the 4-week regimen of 55 gray in 4 weeks and compared that to the accelerated radiation regimen, the Dahanka regimen, that was successful in their previous trial, in a setting where concurrent chemotherapy can be given. And these were the tumor subsites that were allowed: oropharynx, larynx, and oral cavity. Notably, nasopharynx was excluded. I'm glad Anli is on the line. She could give us some insights, but I have some data to suggest why this might be. Another regimen that has captured a lot of people's attention is a 5-week regimen giving 64 gray and 25 fractions. And again, this is a British originated study, and what they do here is give the radiation in 5 weeks, but also with standard platinum chemotherapy that we would normally give with conventionally fractionated radiation. And they make the point, using their BED tables, that if you give 70 gray in 35 fractions, the tumor BED, when you correct for time, is actually inferior to the 5-week regimen of giving 64 gray in 5 weeks, so that there's a potential for treatment intensification with this 64 gray and 5-week regimen compared to 70 weeks in 70 gray in 7 weeks in terms of its impact on tumor control. And that when you looked at late complications, that they're roughly equivalent between these two regimens. Of course, the acute side effects are more prominent with the hypofractionated course compared to the conventional fractionation. And in this pilot trial of 15 patients looking at oropharynx cancer patients, where they looked at both P16 negative and P16 positive, all with greater than a 10-pack-year smoking history, they gave high-dose cisplatin in about half of patients. The other half could not tolerate the high-dose chemotherapy, but were able to receive carboplatin. And when you looked at their results, even though there was significant toxicity, none of them required a feeding tube. And with a minimum follow-up of 2 years, quite respectable results were obtained. 2-year overall survival rates of 93%, with only 1 regional failure and the other 2 having distant metastasis. And another group experience, a good friend of mine had mentioned to me, Tay Vong, who's a chair at University of Montreal, told me that they also had a 5-week regimen where they used slightly less dose, 60 gray in 5 weeks, but with high-dose cisplatin in over half the patients. 49 patients were in the study. The majority of them were oropharynx, but there were some nasopharynx, larynx, and hypopharynx in a smaller subset. And in there, but all of these patients were treated with IMRT. And what they found, again, at median follow-up 2 years, was that there was no grade 4 or 5 toxicity and very low feeding tube rates. So, and with 2-year follow-up, their local regional control was about 83% and very respectable overall survival. They mentioned that long-term outcomes were needed, and this needed to be studied on a clinical trial basis to really bring this to the mainstream. And that, in fact, is something that is a topic right now, a major study that is ongoing right now in England, where they are testing this 5-week regimen compared to the 7-week regimen, conventionally fractionated radiation, in the setting of high-dose cisplatin, either weekly or given as 3 weeks. And then and also looking at other approaches that are thought to might be beneficial in patients with intermediate or high-risk oropharynx cancer. So induction TPF followed by concurrent conventionally fractionated radiation with weekly or high-dose cisplatin, or some people believe that in these intermediate and high-risk patients, that surgery might be still the best treatment possible. The surgeons always, in your tumor boards, look to CAT-ANGs, and when they see the high-risk patient population only surviving about 50%, they believe that surgery might add to better outcomes with risk-adapted adjuvant post-operative treatment. So these 4 arms I highlight to you here in more further detail is being studied with about 700 patients planned for enrollment, and overall survival is the primary outcome. And importantly, quality of life, toxicities of these various treatment regimens, and swallowing function, preserving that important function when you treat the oral pharynx are importantly being looked at this study. I'm going to switch over a little bit to nasopharynx. Are there any questions about that first part of the study? I'm happy to take any questions now, or just proceed and take questions later. Feel free to ask. Okay, so I'm going to just switch over to standard treatment for nasopharynx cancer, where in North America, this medical oncologist named Mui Al-Saraf designed this trial where during this time, it's over almost 30 years that this regimen has been completed, where at that time standard conventional fractionated radiation was the standard, and his concept was to add high-dose cisplatin with the radiation, followed by 3 cycles of adjuvant cisplatin 5-FU. Many of you are familiar with this regimen. And by adding the concurrent and adjuvant chemotherapy, he was able to show a 30% survival benefit by decreasing local regional failure by 2/3 and decreasing the incidence of distant metastasis by 2/3. The problem with this regimen was that only about 60% of patients were able to complete all 3 cycles of high-dose cisplatin, and only about half the patients were able to complete the adjuvant chemotherapy. There's been so much interest in seeing if we can improve compliance by giving induction chemotherapy, and some of our colleagues from the Sun Yat-sen University in Guangzhou have been very instrumental in showing that patients who get induction gemcitabine and cisplatin for 3 cycles, followed by concurrent chemoradiation, when compared to concurrent chemoradiation alone, had about a 4% improvement in survival in those who got the induction, with primarily a decrease in distant metastasis by about 7% at 3 years. And so there was a kind of a discrepancy about how these patients should be treated, whether with induction or with concurrent followed by adjuvant, because this trial itself did not give adjuvant chemotherapy as in the Al-Saraf RTOG trial. So many could say that this was not a fair comparison of a standard of care in many parts of the world. But An Lee, who I'm so glad is on the phone, on the webinar right now, conducted this really seminal trial looking at that question of using that same chemotherapy regimen either as induction or as adjuvant in the setting of concurrent chemoradiation, and also looked at accelerated radiation as a part of a randomization in addition to a different induction chemotherapy using Xeloda instead of 5-FU, and was able to show that patients who got the induction chemotherapy regimen, whether it was with cisplatin 5-FU or cisplatin Xeloda, had an improvement in progression-free survival, in overall survival, compared to those who got the chemotherapy after the concurrent chemoradiation in the Al-Saraf trial, and also showed, importantly, that the toxicity seemed to be lower in the patients who got induction chemotherapy versus those who got the chemotherapy after concurrent chemoradiation. And I bring that up because the hypofractionation in the setting of nasopharynx cancer has not been that successful, I would say, because with nasopharynx cancer patients, there's a very small therapeutic window when you're treating such a large area. Typically, these patients have tumors that
Hello? Doctor Who? I think we lost you.
We lost his voice.
Yes. Hello, Doctor Who. We cannot hear you.
What about time?
Hello, Professor. It is something like a mute.
Yeah, we cannot hear her.
Shall we continue with the panelists? Oh.
Maybe there may be some network problem.
Yes, I think he got disconnected.
What do you think, Shyam? Shall we continue with the, yeah, that's coming, now coming.
Yeah, can we phone him up? Let's see.
I think
Miriam has phone number. Can she try? Otherwise, we can go ahead with the panel discussion.
yeah. Miriam?
Yes, I think Professor Kazi, if you would proceed to the panelists while we wait, please.
I think I can do that. Until Professor Wu is reconnected, we can ask for the panelists' experts' opinion as per the schedule given. I would like to request Professor Ann Lee to share her opinion or remark regarding today's presentation. Professor Ann Lee.
Okay, thank you so much for the invitation. It's an honor. Really enjoy Kenneth's talk. And also congratulations to the organizer during this pandemic, organizing all these educational activities, talking on an important topic, which we hope that can help everyone during this difficult time. So it's wonderful that Kenneth talked about this consensus statement, because actually this is unprecedented. So none of us know exactly what is the best way forward. So how to treat the patients while they have infection and also protect the staff at the same time. So all these consensus statements that Kenneth pointed out are importance of reference for everyone. And also, and then when resources become limited, what should we do? The question of hypofractionation. Now, this is a, I see Kenneth coming back. Kenneth, can you go on with your lecture? I'm just at this very critical, important point on the nasopharynx. I give it back to you. Okay.
Okay. Dr. Hu, you can start.
Please,
Not enough
Professor.
time.
Are you coming back?
Yes.
Yes.
Yes, we can see. Okay.
We can see you, but we cannot hear you yet.
Yes. Unmute yourself.
Okay.
Okay.
Yes.
Yes.
Wonderful. Would love to hear your talk on that.
Again, muted.
I was just gonna, can you hear me now?
Yes.
Yes.
Wonderful.
Yeah.
Okay. So I was just gonna, if you want to comment on, please feel free. I didn't want to disrupt you, but I can complete if you want to wait till afterwards, because there's some other data sets that I want to present, and also hear your opinion about that, because I think you're the right person to make the best comments about this, given all your experience.
Oh, no, wonderful to hear your talk, Kenneth. Please
Okay.
complete.
Okay.
Look forward to
Well,
it.
thank you. Thank you. So what I was saying was that the patients with in nasopharynx setting, there's such a small window of therapy, because with these tumors extending into the skull base, intracranially, as well as having bulky nodes, there's so much chance for complications, not only to the visual and the CNS pathway, but also to the cranial nerves that exit through the skull base and also traverse the carotid sheath, where next to those lymph nodes. So when you're delivering high doses of radiation to these areas, you're at significant risk for multiple complications, including temporal lobe necrosis, cranial neuropathy, radiation-induced fibrosis of the neck, as well as multiple dental issues. And as I emphasized, it is notable that the IEEA in their HYPNO trial did exclude nasopharynx cancer, I think wisely, and that there's also limited data for hypofractionation in the nasopharynx cancer setting. One of the earliest reports, again, came out of our colleagues from Britain, this report from Manchester of 128 patients who were treated with nasopharynx cancers using older technique, primarily 2D radiation to deliver this 4-week regimen or 3.5-week regimen in some of their patient cohorts that they recommended in the setting of concurrent cisplatin, with a median follow-up of 44 months. They don't have, unfortunately, toxicity data, but they report that there was no survival difference amongst the 3 fractionation regimens, pointing to that maybe there is a possibility of treating these patients and getting equivalent tumor control. What they were able to show was that, similar to other data sets, the patients who got concurrent chemotherapy in the left-hand graph were the ones who were able to do better than those who got radiation only. That's something that, even the setting of hypofractionation is important. In the patient, and the patients who seem to do best are those who have the endemic type of WHO subtype, EBV, most likely EBV positive, versus the keratinizing that may be more related to the non-endemic component. As many of you may or may not know, the subtype of nasopharynx cancer can impact outcomes. So here in the United States at University of Michigan, they looked at their cohort of EBV positive patients versus HPV positive patients, nasopharynx cancer patients, or those nasopharynx cancer patients that were both EBV and HPV negative. And they were able to show that even though all of these patients were treated with the standard concurrent chemoradiation al-Saraf regimen, it was really the EBV positive patients who did the best. About a 25 to 30% improvement in survival compared to those NPC cancers that were HPV positive, and even better than those patients who were HPV and EBV negative. So I think that tells us that we have to be careful about if there are regimens that are beneficial with hypofractionation, there might be certain subgroups of patients with nasopharynx cancers that might benefit or might not benefit, depending on their molecular profiling. So in terms of other experiences giving hypofractionated radiation for nasopharynx cancer, This is a 6-week regimen that was done in about 14 patients, again, from our British colleagues, where they got induction chemotherapy in the majority of cases, and they gave a dose of 65 gray and 30 fractions. And it was quite respectable, although short medium follow-up of 17 months, where there was 100% local regional control. However, acute and late toxicities were not reported given the early follow-up. And there was a study conducted here in New York at Sloan Kettering, where 25 patients with advanced stage nasopharynx cancers were treated with a 6-week regimen, delivering 70 gray in 6 weeks with high dose cisplatin, 2 cycles. And at a median follow-up of 30 months, there was a very respectable local regional control of 91% and 100% compliance with the chemoradiation regimen, and relatively acceptable grade 3 and 4 mucositis rates. However, when they looked at long-term toxicity, they noted that there was a significant incidence of temporal lobe necrosis in this patient population, despite having all of these patients treated with IMRT. So I would say for the nasopharynx cancer experience, the hypofractionation, although might be promising in terms of local regional control, we still have to wait for long-term outcomes to see which regimen allows these patients to get through treatment without having any significant bump in severe late toxicity. Now, switching gears to larynx cancer, there has been some interesting data looking at hypofractionated radiation. And the group from the Netherlands, primarily Dr. Al Mamghani, and has reported his results for early stage vocal cord cancers of the glottis, where for these 30 patients in their initial trial, they looked at giving partial radiation with IMT to deliver a 3.5-week course of radiation, 58 gray in 3.5 weeks, using 4D technique to account for movement of the voice box during radiation treatment. And with a median follow-up of 30 months, they were able to show that the local 2-year local control for the partially treated vocal cord lesions had 100% control. And for the patients who had whole larynx IMRT radiation, their control rates were also respectable at 90%, no difference statistically. But what was interesting was that in comparison to some of the other hypofractionated studies, they actually showed a benefit in terms of voice function, so that the patients who got partial radiation to the voice box, to one vocal cord versus whole larynx radiation, those patients getting the partial radiation had a better quality of voice after their treatment. In the United States, there has been a look at using stereotactic radiation to deliver hypofractionated radiation for early stage larynx cancers. This is from the UT Southwestern group, led by Bob Timmerman. And in this patient study of 30 patients, it was not just T1 lesions, such as in the Netherlands study, but also included some T2 lesions. And they looked at gradually intensifying the dose from 50 gray in 15 fractions, 45 gray in 10 fractions, and even 42.5 gray in 5 fractions. And these were the results. This is an example of what they would do using, initially they use gold fiducial markers to be put in the voice box to track the tumor and the organ, but they later just switch over to a non-invasive approach. And you can see this on the lower left column, the low left illustration, patients with a early stage vocal cord who got treated with SBRT 5 fractions. This is the outcome that they showed with good tumor control. And when they looked at their results at a median follow-up of 39 months, they saw that you really do need dose intensification when you're hypofractionating patients. So the 50 gray and 15 fractions only had about a 50% control rate. If you gave 45 gray and 10 fractions, there was a 77% rate of local control. And if you gave the 5 fraction regimen of 42.5 gray, you got 100% control. And even though the follow-up was pretty decent over 3 years, you're just a little bit cautious, because you could see that in the patients who got the either regimen, there were some significant toxicities, including a grade 4 laryngeal edema that required a tracheostomy tube. In the middle regimen, there was a laryngeal necrosis, and in the SBRT, very ultra hypofractionated regimen, there was a retinal necrosis that caused aspiration pneumonia and a feeding tube. So there is some caution about the efficacy of this. It seems like oncologically there seems to be some signal that it could be efficacious, but the long-term toxicities need to be sorted out. So I'm just going to conclude by saying that under the COVID pandemic conditions, conventionally fractionated radiation is still the preferred treatment. I just think that because so many people have so much more comfort with conventional fractionation, that they feel a little twinge of anxiety when they're saying, let's go with hypofractionation, which most people are not familiar with. But only under severe limited resources under the second pandemic scenario would hypofractionated be considered. I think the regimen most that people probably feel most comfortable with is this 55 gray regimen in 4 weeks, although the 64 gray in 5 weeks seems to be also favorable, and that might even have an added benefit of improving outcomes compared to those getting conventionally fractionated radiation. There are 2 ongoing randomized trials that are looking at these 2 regimens. From my understanding with Miriam, the Hypno trial is completed, and I think we're looking forward to the results of those of how that compares to the Dahanka regimen. In the patients with oropharynx and early stage larynx cancer patients seem to have the most promising early experiences. Nasopharynx cancer needs further evaluation. On has been so great at demonstrating that induction chemotherapy is the way to go for these stage 3 and 4 patients. Perhaps after induction chemotherapy, one might consider a hypofractionated regimen if there's been a lot of regression off these critical pathways or shrinkage of these big lymph nodes. Ultimately, all of these regimens are going to be evaluated and judged based on the long-term toxicities and the quality of life and function preservation that they offer compared to conventional fractionation. So at this point, I'd be happy to answer any questions or have Dr. Gupta and Dr. Lee make some comments from their perspective. If not, I do have a couple of cases that I brought in case we want to have a discussion, a case-based discussion.
Please, Dr. Kasi.
Should we continue? I think Dr. Hu should complete his presentation with the case discussion. Or if you think we can take the opinion from the panelists. We have time.
Okay, great. So maybe I'll just go ahead.
Dr. Andley, do you want to comment now, or you want to comment after the presentation is completed? after the
I
case
would love to
discussion.
hear Kenneth's cases. I think they I'm sure they will be very important to supplement his talk. Okay, so let us hear the case discussion first.
Okay.
Yes. Okay. Dr. Hu, please
Okay.
continue.
All right, Dr. Sam. So let me just talk about a typical scenario. A patient who's 50 years old who presents with a left-sided neck node measuring 3 centimeters. His imaging studies show a tiny primary site in the tonsillar bed, 1 centimeter, without any obvious involvement of the soft palate or the tongue base. And on the workup, there's a left level 2 lymph node and a left level 4 lymph node, both less than 3 centimeters without any overt extracapsular extension. And the CT of the chest shows no evidence of lung disease. The patient was one of the nodal masses was biopsied through fine needle aspiration, and it showed a squamous cell carcinoma. And so, in this pandemic scenario, let's say, do you think P16 status is important? Would you get something like that? So I asked the panelists, is P16 necessary? Would it change the way you would treat patients in a COVID environment? So Dr. Gupta, I haven't heard from you. Maybe we could have your point of view.
Yeah. Good evening, everyone. As you've put it, if it is P16 positive, by the new AJCC classification, it becomes a stage 1 disease. And if it's P16 negative, then it becomes a stage 4 disease. I think pandemic or no pandemic, I think P16 should be done for all oropharyngeal cancers. And it may not necessarily change the way you treat the disease, but it certainly, the prognosis is hugely different. And I think we would want the P16 to be done on this patient as well.
Great. In a pandemic scenario, how would you treat a patient like that? What fractionation scheme, and would you give concurrent chemotherapy?
So in outside of the clinical trial, so we were part of the Hypno, and these patients, they were being staged by the AJCC 7th edition, and this would P16 positivity would not change that. So this would become stage 3 T1N1 as per AJCC 7th edition and be eligible for the Hypno study. In the Hypno study, as you said, we were randomizing to the Dehanka regimen versus the 55-in-20. But outside of the clinical trial, these patients we treat with a modest accelerated regimen, which is 66 Gray in 30 fractions to the high risk target volume and 54 Gray in 30 fractions to the low risk target volume. In the pandemic scenario, probably we would be, given our experience with the Hypno, I would not be very hesitant to treat this with a 55 Gray in 20 fraction regimen.
Mm-hmm. So you've had a very good experience with the 55 Gray regimen.
So we've randomized over 200 patients at our center, 1:1 randomization. So 100 patients we've treated with the 55-in-20 regimen with concurrent cisplatin.
Great. So you would feel very comfortable with the hypofractionated regimen of that 4-week,
yes.
even without the Hypno study.
So now, in hindsight, with the experience of the Hypno study, I'm very comfortable giving 55-in-20 with concurrent weekly cisplatin, not the high dose 3-weekly regimen, the weekly cisplatin.
Great. So it sounds very favorable in terms of toxicity and outcomes. Did you feel that these patients can get through the treatment without needing a lot of nutritional support, including a feeding tube?
Yeah, so the way we use the feeding tube, it is not, we don't use prophylactic pegs or feeding tubes. It's only when there is significant mucositis leading to weight loss, then we put in the tubes. I don't have the data as yet, but I think less than 25% of the patients needed a feeding tube placement, and that was in either arm. I mean, even the Hanka regimen with the 66 grain, 33 fractions given over 5.5 weeks, 6 fractions per week, with the concurrent weekly cisplatin, I think there wasn't any significant difference in the acute toxicity and the rates of. I mean, I don't see the treatment getting interrupted in a significant proportion of patients. The feeding tube probably would be required in 20 to 25% of the patients.
Got it. Yeah, it sounds like, you know, with the shorter course radiation, it seems like patients are pretty much able to get through that. It's just that the week or two after is when they're at risk for really having a problem that might require a feeding tube.
Yeah. Most of them would complete the treatment, and we would actually call them in the 5th week after completion of therapy as well, because you're right, many of them actually towards the end of treatment or actually after the treatment may require a feeding tube placement.
Miriam says that she's put a lot of patients on the Hypno trial. Has that been your experience?
Not quite a lot. We only had very few, I think less than 20 patients in our institution, but we had almost equal normal fractionation and hypno. And the experience is the same as what Dr. Gupta was saying, that as far as feeding tube, either would need or some of the patients wouldn't need at all. And toxicity wise, they were able to endure it without much difficulty. And the ones that are surviving, we still have a surviving patient still until now. Yeah, under the hypno fractionation.
Great. For someone with P16 negative cancer that might have a little bit more aggressive, poor prognosis, would either of you done anything differently?
So in the pandemic scenario, I think we would still go ahead and treat it with the 55 in 20 along with the concurrent cisplatin weekly. As I said, outside of a clinical trial, we don't use that regimen. So if there was no pandemic, then the P16 negative would also get the conventional, I mean, so-called moderately accelerated 66 in 30.
Mm-hmm. Great. In this scenario, do you notice any changes in the patient's function preservation in terms of swallowing or fibrosis or issues with osteoarterial necrosis? Because a lot of these do have these issues. Sometimes when people, in very rare but limited cases, if they have huge neck nodes, which you commonly see in patients with small primaries and large neck nodes, especially in the P16 population, do you find that there's any change in their long-term lymphedema / fibrosis and quality of life?
So that data is still not analyzed. I mean, just for the benefit of everyone, I would like to inform that the Hypno uses co-primary endpoints. So loco-regional control at 3 years and late toxicity at 3 years. These are co-primary endpoints, and this is a non-inferiority design. And the trial would be, so hypofractionated 55 in 20 would be considered as non-inferior only if both in terms of loco-regional control as well as late toxicity, we meet the endpoints. But I mean, out of the 800 odd patients, we've treated 200, and I do feel that the layer effects might be a bit more. This is just my, I mean, sort of personal impression. We haven't done the analysis of that data, but I think fibrosis, subcutaneous fibrosis, when I see these patients in the clinic on follow-up, by there could be a recall bias because I have treated all these patients, but I can actually feel and sort of make out that this is likely to have been treated with a hypofractionated regimen versus the normal fractionated regimen. So I have a feeling that the late effects, particularly the fibrosis, might be more, but I really cannot say with great conviction because we haven't analyzed the data as yet.
Yeah, I think having those two co-primary endpoints is very, very thoughtful, because you know the Arlene Forcier study, the 9111 larynx trial, that was a second generation after the VA regimen, where they in the second generation trial they compared induction chemotherapy followed by standard radiation versus concurrent chemoradiation versus radiation only. When you look at 10-year outcomes, even though the patients who got concurrent chemoradiation, the standard of care that many of us use for stage 3 and 4 larynx cancer, that these patients, you know, getting the concurrent, even though they had a 20 to 25% improvement in local regional control and organ preservation, their survival rates were actually worse compared to the patients who got induction versus radiation only at 10 years. And there's a belief that it's the late toxicities of the concurrent chemoradiation that has done these people in, causing a lot of non-cancer mortalities. And so many believe that it could be related to, you know, dysfunction for swallowing, with the fibrosis causing a lot of aspiration pneumonia, and that debilitating them and causing their non-cancer related death. So I think that it was smart that there's a recognition that these long-term toxicities are very important in ultimately giving, you know, the final outcome about the best regimen.
If I can just qualify that statement, the Forestier RTOG 9111 used the 3-weekly cisplatin, which is the so-called standard. But if you look at the NCCN guidelines also, after induction chemotherapy using the TPF regimen, actually it's not recommended to use 3-weekly high-dose cisplatin as the concurrent regimen. So I think most people are now cognizant of this fact that if you give induction chemotherapy, then your concurrent chemoradiotherapy, either you do RT alone, or if you're using the concurrent chemoradiotherapy, then it should not be the 3-weekly high-dose cisplatin.
Yeah, I think everybody agrees with that for sure, especially since there are now some data that show that the weekly versus high dose, you know, at the recent ASCO seems to show that the weekly might be as good, if not better, than the high dose. You know, unlike that other trial that was run out of Tata, where they showed that the weekly was inferior to the high dose, but this others trial seems to show weekly is as good, if not better.
Maybe you can also go ahead and say so.
Okay, so then the second case that I thought might be helpful, just that Anli is on, is a nasopharynx cancer patient who presented with a you know, mass in the left fossa of Rosenmuller extending into the retropharyngeal space, into the oral pharynx with retropharyngeal nodes ipsilaterally and bilateral level 2 lymph nodes. The biopsy was done that showed an EBV positive non-keratinizing carcinoma, stage T2N2 by 7th addition staging mechanism, and you can see here the left nasopharynx mass with the bilateral neck nodes on CT and also MR. So, do you think that there is any potential benefit of hypofractionated radiation in the setting of induction chemotherapy?
Kenneth, now for the nasopharynx, as you pointed out, the therapeutic margin is very narrow, so has to be very careful. So I can see that for this case, bilateral, actually quite extensive lymph nodes. So number one, must exclude distant metastasis. So make sure that this didn't happen. So presuming it's a T2N2, the ASCO guideline for chemotherapy has just come out, and we have extensive discussion. So the panel would feel that induction first. There is information, I mean, for the other trials that compare concurrent alone, obviously they show that induction plus concurrent is better. But even when when we compare the induction plus concurrent versus concurrent plus adjuvant, for those who are using conventional fractionation, still is better. The reason actually is the dose of platinum which we've been able to get in. So the adjuvant phase obviously is not that easy to tolerate, whereas the induction phase, almost all the patients can get the full dose or close to a full dose anyway. So that's why it might be better, particularly because for nasopharynx, it is particularly important that there is this concern about distant failure, which is the most important one. Now, coming to your questions about hypofractionation, be very careful for the nasopharynx because there are so many critical structures surrounding. So the toxicity can truly can be increased. When we talk about hypofractionation, there are two aspects. Number one is time. So when we say 70 gray in 6 weeks, now, so this is the time issue, shortening by 1 week, but also has to take note of the dose per fraction, because more than 2 gray per fraction is different from 2 gray per fraction. So that the Hanker way of doing 2 gray per fraction, but 6 fractions a week, meaning that there is still 24-hour interfraction interval, giving more time for repair of sublevel damage may be important. So that's why for this, we truly has to be careful. Now, for the 0501 trial, I learned my lesson too. I want to answer so many questions. That's why you can see it's such a complex design. Besides wanting to test induction plus concurrent versus concurrent plus adjuvant, that is my number one goal. Number two is I want to see whether the mild hypofractionation using 2 gray per fraction, 6 fractions a week is also possible, or hoping that it might even further add to the benefit, but it didn't. The reason why it didn't is complex in a sense that the fractionation and the chemotherapy, the changes are very dynamic. So with induction chemotherapy, the ability to tolerate concurrent chemotherapy is mildly compromised, although not excessively. And if you use hypofractionation, then the dose of concurrent may even go lower, and that may affect the ultimate outcome. So for us in the 0501 trial, we see that if we use the accelerated fractionation, moderate accelerated fractionation, then induction plus concurrent didn't achieve the benefit over concurrent adjuvant as shown for those who are treated with conventional fractionation. So it's indeed very complex. So it's true that I fully agree for when a situation is compromised. For the other hand, neck cancer, we can consider moderate sort of a hype of acceleration, but again, as just discussed, be very careful about late toxicity. That's my my feeling.
Great, very helpful. Yes, I noticed you focused on conventional.
There are so many questions in the question
Yes.
and answer box. Should we take some questions during this discussion, or you would like to?
Yes, please.
There are questions from Dr. Shravani Lashkar. Volumes for definitive and elective radiation with curative hypofractionation. Same type of question. Is there a limit to the field size when considering a hypofractionated regime for 55 gray by 25 fraction, even with IMRT? Is there a limit for field size?
Yes, I think that's a very important question. I honestly, I would defer to Dr. Gupta and Dr. Kalagwas, people who have, and Dr. Laskar, I'm sure, has been part of this trial, where your sense is that using a smaller field size to make sure that we minimize treatment of some of these critical tissues, especially the cranial nerve pathways and the amount of, normal tissue at risk, I think is going to be key. And that's why I was kind of asking in a indirect way, Dr. Lee, or any else, other people who might consider induction chemotherapy, because there was an interesting trial for nasopharynx for the induction regimens, where evaluating the post-induction GTV and treating that to the full dose it can give equivalent results as those patients getting the initially treated area to the standard dose. So typically, when you look at those papers, after induction chemotherapy, both the nodes and the primary site shrink about a third of the volume. And I thought, maybe this might be a good way to introduce hypofractionation in an induction setting. But I still think that with 2/3 or half of the disease there, you're not going to spare that much normal tissue. But I would agree that limited volumes, the number that threshold, which has yet to be defined. I think when we see what the Hypno trial shows and relating it to long-term toxicity, so smart that they collected both in equivalent high priority, I think that'll give us some insights. But you're right, I think it's going to be small volume disease that's going to probably be the best. And maybe the other issue is that with better technologies, there might be adaptive real-time adaptation of the tumor volume. So some of the institutions are going to be looking at using the MRI LINAC, right, where an MR is going to be done. Images of the tumor can be acquired by MR, and if you have the proper signaling of where active disease is, you might be able to continually shrink the tumor, the radiation tumor volume, especially the high dose, giving the hypofractionated, to smaller and smaller field as time goes on, real time, rather than waiting, a one-time adaptive replan in the middle of treatment. Typically, we do it at week 3 or 4. But if you can do it real time, maybe that might be a way to introduce hypofractionated radiation so that we can minimize the long-term toxicities from it. It's all theory and brainstorming, wishful thinking perhaps, but I think that you're right on the money about trying to minimize the volume, getting that high dose fractionation. In the larynx cancer setting where I showed, I think that's a small volume area, early stage larynx, so it's probably pretty feasible to do hypofractionated radiation in that setting. Certainly in the Dutch experience, where they gave moderately hypofractionated radiation of over 3.5 weeks, that small volume of disease seemed to tolerate it with good maintenance of function. So I think very, very important and excellent points. Do you have any Do you have any thoughts about that yourself, Dr. Laskar or Dr. Gupta?
So, I mean, hypno excluded the nasopharynx. So typically, for the reasons that you pointed out, I mean, it's large volume disease, cranial nerves and brain coming into the field. And I think it's sort of a no-brainer that the smaller the volume of disease that you treat, it easier it is to do the hypofractionated regimen. Having said that, I think any oropharyngeal or hypolaryngopharyngeal cancers that we treat with curative intent, with definitive radiotherapy 1735 can be treated with the hypofractionated regimen. Of course, the smaller the volume, the easier for the patient and the treating oncologist.
Great.
We have many questions. Is there any age limit to consider before hypofractionation? Is it safe in elderly patients? Questions by Dr. Dipali Borde. And what about the acute and late toxicity when you use hypofractionation in head and neck cancer?
Well, for these hypofractionated regimens, I think there is a rapid increase in intensity of the acute side effects, but actually these patients probably recover a little bit quicker because of the rapid onset. There's a rapid recovery. That's my sense of these hypofractionated regimens. Now, in terms of long-term toxicities, the dose per fraction is something that is very concerning, that Dr. Lee had pointed out. It clearly, with conventionally fractionated radiation, when you look at very sensitive structures, the University of Florida has looked at this, especially for the visual pathways and the brainstem, that the dose per fraction has much more serious impact on long-term toxicity, so that when oftentimes we are in a situation where, for example, the optic nerve or the optic chiasm are at risk. We would never want to use a hypofractionated regimen around that area. We try to keep it to, doses less than 1.9, 1.8 per fraction, so that we can maximize the tolerance above what we normally accept. Typically, we accept a tolerance of 50 to 54 gray. But if you keep dose per fraction low, 1.9, 1.8, you can actually bump up the tolerance to the optic structures to about 60 gray and still have a reasonable chance of preservation of the eye, of vision. So I think these are all very important questions that still need to be determined, because there's so little experience. You see the patient numbers that have been looked at in these early phase 2 trials, maybe 20 to 30 patients. To have that kind of data on that granular level requires big trials, such as the IEEA and that COMPARE trial from England. So those questions are obviously going to be something that everyone's going to be looking at. But getting excellent, functional outcomes and quality of life assessments prospectively is, to me, the key to answering those questions.
Thank you. There are many questions. Do you recommend concurrent chemotherapy with hypofractionated radiotherapy? If not, why? And I take another question. Should we go hypofractionated radiotherapy in 2D technique? Is it?
Yeah. I mean, I can ask the other panelists. I don't have to answer all of them, because I feel that my other panelists probably have more experience with hypofractionation, but my sense is all of, these hypofractionated radiation schemes should be done in a very precise way, typically with IMRT, just because you want to minimize the amount of normal tissue that gets exposed to these high dose per fraction regimens. And and as you can see, with hypofractionated radiation, it doesn't serve as a substitute for not using chemotherapy. I think that for the majority of cases, the hypofractionated regimen should be done in the context of concurrent chemotherapy, and that's what's allowed in both of these two trials, both the Hypno trial as well as the COMPARE trial. Maybe in very selected cases of very favorable risk oropharynx cancer, maybe hypofractionated radiation might be helpful. But there was a study even for the most favorable risk HPV positive patients that was just reported by the NRG group, where when radiation dosing was reduced, there was still a benefit for concurrent cisplatin in that setting. So I would say for now, if you're going to use hypofractionation, you should consider using concurrent chemotherapy for these stage 3 and 4 patients. Dr. Gupta and Lee, do you agree?
I completely agree. I mean, I think the hypofractionated regimen that you select, you have to be comfortable that you can give the concurrent chemotherapy with it. So I don't think it's a good idea to choose a hypofractionated regimen where you are afraid to add concurrent chemotherapy. Concurrent chemoradiotherapy should remain the standard of care. The regimen that you choose for hypofractionation should get integrated, and you should not be afraid of using concurrent chemotherapy with that. So which means if you want to use 2.4 gray or 2.3 gray or 2.5 gray instead of the 2.75 that the Hypno uses, I think that's also fair enough. You should not omit concurrent chemotherapy because you think that the toxicities are going to be too high with the hypofractionated regimen. Coming to the 2D technique, I think the Hypno allowed 2D/3D radiotherapy, although several centers did IMRT only. At Tata's, we also did only used IMRT technique. So what you said, Dr. Hu, is perfectly justified, that you would want to reduce the volumes receiving high doses of the hypofractionated regimen. So the best way to do is to use an IMRT approach. But there are several centers that have done 2D and have not really reported very significant acute toxicities. I think the late toxicity data still needs to be evaluated, but acute toxicities have not been too dramatic, even with the 2D approach using the 55 in 20 in the Hypno study.
Thank you. Another question: what delta value is set for Hypno? And with the current COVID situation in the US, is MSK hypofractionating head and neck patients?
Because especially here in New York, we have very few patients who actually, if they are COVID positive, they get delayed. But once they get started, fortunately, there's been so much effort placed in protecting the staff, so that with proper PPE, we have not switched over to hypofractionation regimen. We have not, because the incidence of patients having COVID on most of our services is less than 1%. So we have not switched over yet. But what we did do to get ready for it is that I actually called Dr. Thomason over in Britain to get the parameters for the 5-week regimen. So I tend to, if I'm going to revert to the hypofractionated scheme, I would go with the 5-week regimen.
So the Hypno actually uses a non-inferiority margin or delta of 10%. 10% is the upper bound of the non-inferiority margin. That's what is in the protocol of Hypno.
Thank you, sir. Thank you very much. for the nice presentation and elaborate discussion. But we are at the end of our time. We have very short time we have. So I would like to thank and say goodbye from my side. I'd like to hand over my mic to Professor Miriam Calaguas for the concluding sessions. Thank you. Thank you from my side.
Thank you
Thank
very
you, Dr.
much. Yeah, sorry. Thank you very much, Professor Kazi, for being the moderator. And we would like to thank our special guests for an excellent and very, very timely lecture on this topic of hypofractionation in head and neck. We also would like to thank our two distinguished panelists, Dr. Ann Lee and Dr. Tej Palgupta. Dr. Kenneth Yu, you made our night tonight by giving us an excellent lecture and learning a lot from all of this. And hopefully it's the way to go during the pandemic, COVID times, although we still would prefer conventional fractionation. There are still questions to be asked about it, the late toxicity. But on behalf of the FARO officers and the council members, we would like to thank our special guest, Dr. Kenneth Hu, and our panelists, and also our organizing committee, and headed by Professor Tati of the EROS and Aurora, and of course, Dr. Mayang, the voice that you hear earlier, and and all our members of the FARO and our guests and all the participants who attended. But I don't think I'm the last speaker. I think Dr. Tomo Tamaki will have something to say. From my end, I would like to thank everybody for joining us tonight. And thank you and good night. Dr. Tamaki, please.
Okay, thank you. Can you all hear? I would like to make just a short comment since it's late. Thank you, Dr. Hu and the two panelists, Dr. Gupta and Dr. Lee. I think the seminar was very timely, but at the same time, it has the potential for our future development in our radiotherapy for head and neck. Even after the COVID, this hypofractionation regimen would definitely benefit the patients worldwide, but especially in our region where we have a large volume of patients compared to other regions. So thank the presenters again, and also the organizers in Indonesia. It has been a very excellent webinar. I counted more than 400 participants at one time, and this was a very big success, I think. And we hope to continue that in our future webinars. So thank you, everyone. And I'll hand the microphone over to Mayan.
Okay. Thank you, Doctor. Thank you, everyone. And so we're at the end of our event. Thank you for all the participants who have logged into our event. And to finish our session, would all the panelists turn on their video? We'll take a virtual photo shoot. Dr. Hu, could you turn on your video?
Yeah, this is the rub about by joining through my virtual network. Because of firewalls at my institution, by doing the virtual network, it doesn't allow me to turn on the regular Zoom controls. That's why I've been my picture, my camera been off. I did. So
Okay.
it's a little fun.
We are sorry
Can
we
I
miss
show
you.
you? Can I just send you my? Can I
Yes.
just send you a stock photo of me when I was 15?
Well then, okay, we'll add you in then later. Okay,
Thank
so
you.
okay, so for Dr. Maheta, maybe you could lead the photos.
Okay. Okay. Yes. Thank you. Professor.
Moment, please ask all the men behind the screen, the recorder, the admin, the timekeeper,
all the team member.
Yeah.
Show yourself.
Turn on your video, and also Dr. Sarbani, can you turn on your video, please?
Oh, okay. I think can I invite Professor Sarbani to the panelist?
Yes, and Dr. Sarbani is here. Yes, ma'am.
Sarbani, can you make your video on?
Yes, yes.
Sir, I don't have the option, sir. It's okay.
Oh.
I enjoyed the session. It's all right, sir.
Great, great.
Okay, madam. Thank you.
Okay, okay.
Okay.
Yeah,
Maybe Sarbani can also send the photo, so you can add.
Yes.
And
yes, of course.
Okay, then I will begin taking our picture. I will count to 3, and please hold your pose for a moment since we have a little bit of lag time. So, okay, if everyone ready, 1, 2, 3, smile. Okay, thank you very much. Oh, one more. Okay. This pose, bro. Okay.
Yes.
Okay.
One. Okay.
It's loud. Okay.
1, 2, 3. Okay. Thank you.
Great.
Professor.
Thank
you, everyone.
Thank you.
Mayang, can you explain about the question that is not yet answered? Is already.
Yes.
Yeah.
Yes, I wrote on the chat also that we will compile all the unanswered questions, and we will try to forward to all the speaker and panelists if you don't mind to answer them, and then we will send it to the attendees.
Yes,
that will be good. Very nice.
Yeah, I can put the answers on the website too.
Oh, okay, Doctor. Doctor, who is your video is on?
A video is on? Seriously?
Yes.
Yes.
Your video is on.
Oh, yes.
You are not seen.
Now.
Doctor Who, we cannot see you.
Yes, only we need your face there. Yeah.
Yes. Okay.
Again.
Like it, Dr. Mahesa.
Another picture.
Ayo Mahesa again. One more.
Okay, one more time.
Where is
Hello,
recorder?
Professor.
Okay, who is recorder?
So you want both the action like this and that?
Yeah.
This is love. Love.
This is love.
Make love, a small love.
How?
Okay. I will count to 3. 1, 2, 3. Smile. Okay, I believe I've taken the photo. Thank you, Professor.
Thank you very much. Thank you.
Bye-bye.
Thank you.
Thank you, guys. Wonderful job.
Thank you very much.
Awesome.
Terima
Bye.
kasih ya semua.
Hope to meet you soon.
Terima kasih, Prof. Thank you.
Bye-bye.
Bye, Prof.
Great. Thank you. Thank you very much.
Miriam, Prof. Kazi, thank you. Bye,
Ayam,
Dr. Hu.
Sham, Junlin. We're
Bye.
Tomo.
Thank you.
See.
Thank you, sir. Thank you.
My friend Ken.
Thank you.
I can't believe the camera works.
Bye.
Yeah.
Bye. Take care, Sham.
Thank you. Thank you.
Thank you, Professor Hu, for the nice lecture.
Thank you, Ken.
You bet. A pleasure.
Great.
Thank you.
It was lovely lecture, Kenneth.
Thank you.
Mas Esa, sebentar jangan di stop dulu ya. Aku lagi compile questions-nya nih. Bentar lagi beres.
Oh, ini mau ini ya? Kayaknya kalau nggak salah bisa di-download deh. Coba aku coba dulu ya sembari di compile.
Kalau nggak salah bisa di-download ya di apa?
Di-download ya. Caranya
bisa di-download chat dan apa ya?
report. Bentar coba. Gue coba dulu.
Bisa nanti aku sambil taruh ini.
Oh ini belum ditutup, jadi nggak bisa di generate reportnya.
Dari Putri bilang setelah selesai bisa di-download guys, nggak usah di sini katanya.
Oke. 5 menit, gengs. Tanggung banget, gengs. Tapi bisa ini nggak sih?